In terms of the toxicity of the combination of dabrafenib and trametinib, one of the more common adverse events is fever. We manage that with the usual antipyretic therapy. Sometimes it does require dose reduction or dose interruption. Other toxicities include cytopenias, anemia has been reported, neutropenia has been reported. GI toxicities like we see with most of the TKIs can be present. I think in terms of looking at the higher grade toxicities, pyrexia leads the list, but all the other ones are, in terms of grade 3 or 4 toxicities, in the single digits. So, I think many of us would, in this situation, characterize this as manageable. Again, we've had this regimen out there in the melanoma population and used quite frequently in that population. And again, I don't know that I'm not aware that actually that there are any different safety signals in the lung cancer population relative to the melanoma population with this combination. The use of agents such as acetaminophen or steroids, give patients breaks from therapy to let them resolve the toxicity. It's not a very common reason to have to discontinue the regimen. So I think you can work with dose as well as the antipyretics so that patients can stay on therapy, which is important if they're having a response to stay on therapy. So I think, again, I don't know that it will, I'm thinking in the majority of the cases it will be more of an inconvenience than it is a reason that the patient can't continue on treatment. One of the initial experiences I had with this combination was a relatively young lady who was highly symptomatic from her recurrent pleural effusion and lung disease. This was a lady that lived in a relatively rural area, and one of the things that she enjoyed doing was walking her dogs. Whether it was, when you live in a rural area, sometimes your mailbox is a ways away from where the house is, and there was a river she would walk the dogs around, and she got so symptomatic that she could not either get the mail or take her dogs for a walk, so she ended up really being housebound. And we saw her, we were aware that she had the V600E BRAF mutation. We enrolled her on the clinical trial of the combination of dabrafenib and trametinib. And she started on treatment, and we saw her back a week or two later. She said that within 3 days of starting this therapy, she was able to get the mail. I mean, she felt this was a miracle. She actually, it was a very touching moment when she kind of looked at me and she said, I never thought I was going to be able to leave my house again or walk my dogs again, and I'm doing it again, and I feel so much better just taking these pills. And so that's the kind of experience you can have. All of us who do lung cancer for a living, when you start to find these EGFR mutants or ALK or ROS1 or BRAF or exon 14 MET skip mutations, these patients can be very sick, and with a matter of days with the appropriate targeted agent, you can turn them around. And that's very gratifying from a treating physician point of view. In this BRAF patient, it was kind of one of the most remarkable stories that I've heard. And subsequently, every medical student I had following that, I'd make her tell her that story, just so medical students would get the impression that lung cancer is a potentially treatable disease. And lung cancer is very heterogeneous, and you have to look for these patients. Patients aren't going to tell you, hey, I'm BRAF positive. You have to get enough tissue to test for it and know to test for it. And I think that's the lesson learned. In this patient, again, I think she should be treated with the combination of dabrafenib and trametinib. We don't know it. We don't believe it's curative therapy. At some point, she's going to progress. My sense would be to treat her in the third-line setting with immunotherapy. She did not have any contraindications in her history that she couldn't get immunotherapy. even though she was PD-L1 negative to start with. We know, for instance, the drug atezolizumab, whether you're PD-L1 positive or negative, it seems to have a similar effect. We know from the nivolumab studies that there's activity in the PD-L1 negative population. So, PD-L1 is a complicated biomarker, and we clearly do see activity of the immunotherapy agents to a lesser degree, but still there is activity there in the PD-L1 negative population. So following progression on this case in the third line setting, I would recommend probably either atezolizumab or nivolumab as her next choice.